Hi, everybody. Thank you for attending today, and hopefully we'll give you kind of an overview of how important it is that we manage pain in all of our patients, but especially when it comes to our dental patients. Oops, gotta get my clicker to work here. There we go. So when we're talking about pain management in general, we really need to look at what we call balanced anesthesia and balanced pain management. And when we're using anesthesia, which we need to do when we're doing our dental patients and doing a COHAT or comprehensive oral health assessment and treatment or professional dental cleaning, we need to use balanced anesthesia. And that means we're going to use a multiple different drugs. And the reason we use these different drugs is because they're going to actually minimize, if we use, they're going to minimize the drug effects, but it also maximizes their benefits. So we're going to be able to use less, but get more bang for our buck. It's also really important that we tailor our anesthetics and our pain management to the specific animal. The days of just everybody getting cat val hopefully are gone. We're using drugs that are going to be more tailored to what that specific animal needs based on what, their blood work is or whatever else is going on with them. There's occasionally times we really always should be using pre-medication before we do any kind of induction for any type of anesthesia. Because it does help reduce that patient's anxiety. And when we keep that anxiety lower, it means we can use less drugs for the anesthesia. One of my big things is preemptive analgesia, where we're going to be giving some type of pain medication prior to the procedure. This is just going to not only help everything go a little smoother, but we're actually aiding in the pain that can happen during a procedure. Yes, the animal's under anesthesia, but they can still sometimes feel pain. And anybody who's assisted in a surgery knows that when the doctor's getting ready, even on an ovarian hysterectomy, is getting ready to, tug a little bit on the ligaments, you kind of crank the anesthesia up a little bit because the patient's going to feel it. So the advantage of using preemptive analgesia is that it kind of helps take a little bit of that away. And that can be any of these drugs that are listed. It could be midazolam, it could be diazepam, acepromazine could be used. Dexamethasone is another one that's there. But all of these are going to have a profound effect if they're used in conjunction with some type of opioid. Now, we can also do an anticholinergic in there. That's kind of one of those things that's, you still do it or not, whether you're giving an atropine or glyco prior to a procedure. But, it's something that's a doctor's decision on whether we want to do that. There are better choices when we're talking about dentistry than others. And when we think about a dental procedure, especially one where we're doing extractions and surgical extractions where we're cutting bone, which is an orthopedic surgery, we need to make sure we're giving this patient good, strong pain management. And that means, I don't have it on this slide, but torbuterol or butorphanol really isn't a very good pain management system at all. It's kind of like having knee surgery and taking an aspirin. It's not going to, do a whole lot to really help that patient. We really need to be looking at more of the pure mu opioids, such as hydromorphone, methadone, morphine, even sentinel CRIs, constant rate infusions for these patients, because we are inducing a lot of pain in these patients and we want to make sure they're comfortable. So you can see here with hydromorphone, yes, it can cause hypothermia and dysphoria in cats. We know that. Methadone is a better option for cats. Okay. Morphine will sometimes create pretty heavy sedation in addition to pain management. We can have allergic reactions and really shouldn't use in cats at all. But just be aware that these are options that we should be having in our clinics so that we can offer these patients the best pain management we can. Now, whenever we look at a dental patient, usually these patients are at a higher risk. They have a comorbidity with them in addition to really bad mouths or whatever might be happening to them. They might have diabetes. They might have a heart condition. Most of those can be actually related to the dental disease they have. But they're going to be older. And one of my least favorite things I hear is that when I hear someone, whether it be a client or even a veterinarian, tell somebody that their patient is too old to have anesthesia. And that really really hurts me because age is not a disease. It's just a consequence of not dying. And we would not want to put our elderly grandparent, you know, if they fell and broke their hip, to have surgery to fix that, because, and we won't, you know, say, well, we can't do it because they're too old. So with proper management, proper anesthetics, and proper monitoring, older patients can have these procedures done. A lot of times dentistry is still considered an elective procedure. We just don't think about it as being a preventative is where it needs to be. It needs to be a preventative, like we brush our teeth every day. We still get a professional dental cleaning every 6 months or every year. We really need to be looking at that for our patients. Everything that's happening in the patient's mouth is happening, that happens in our mouth can happen in a dog and cat's mouth. So we need to be a little bit more proactive on getting these away from being considered an elective procedure, but make it a preventative procedure instead. And a lot of times we don't get a lot of training in school. Fully admit that, whether you're going to vet school or vet tech school, you don't get a lot of training on dentistry. And it's getting better, but it's not there yet. But we don't put enough emphasis on the patient's safety when it comes to a dental procedure. And that means that, you know, back in the day when I started this, you know, all dental procedures were in a back room, back of the clinic. So nobody had to listen to the scalar sound. And you were there by yourself trying to clean the teeth and monitor the patient. Well, it's really hard to do that. I'm really good at what I do, but I can't monitor a patient at the same time I'm cleaning their mouth. It's going to take me twice as long because I have to stop every 5 minutes or so and do a vital signs. All these patients need to have a dedicated anesthetist. Any patient under anesthesia, I don't care if it's a spay-neuter or if it's a dental procedure, need to have a dedicated anesthetist and constant monitoring. And that means more than just a machine hooked up. The monitors that we have are usually about 90 seconds behind what's actually happening in the patient. So a little bit, I'm not going to get in too much about nociception, but nociception is the perception of pain. And we know that the anatomical structures and the neurophysiological mechanisms in humans and animals are very much alike, okay? So if something hurts us, it's going to hurt the dog. So I always tell, you know, I meet with a lot of veterinarians, and sometimes I get the, well, you know, dogs don't really and animals don't really feel pain, so we don't need to worry about this. And I'll ask him, I said, well, have you ever trimmed a toenail too short? Well, yeah. Well, has that animal cried in pain? Well, yeah. That's because it hurts. Okay. So we have to make sure they understand that what's painful to us is going to be painful for that animal. So there's 4 pathways, 4 parts of the pain pathway, and I'm not going to get into these too much, but transduction is what happens at the site of the injury. So let's say I cut my finger. Okay, so that's transduction, the laceration, or I touch a hot burner, that's transduction. What happens then is transmission. So that sensory is going all the way through my sensory nerves, okay, up to my spinal column. When it goes through my spinal column to my brain, that's called modulation. And then when my cerebral cortex in my brain suddenly, oh my God, it hurts, that's perception. So we have the 4 pathways here: transduction, transmission, modulation, and perception. And the role of balanced pain management is to kind of had pain management at each of these steps in the pain pathway. So we're going to talk a little bit about nerve blocks and local blocks. That's going to be kind of right at the site of the injury. All right. Then we're going to give some medication that might work in the transmission and modulation. So, you know, we have all these different pathways covered. Now, we know both from human and from veterinary world that there is such a thing as pathological pain. And when we have pathological pain, that means this patient is going to be at a greater risk for infection. Their wounds aren't going to heal as fast as they would if they were pain-free. They're probably not going to want to eat or drink. And when they're not eating or drinking, they're missing valuable nutrients that their body needs to heal. So we want to make sure they're eating and drinking. A lot of times they may become immobilized. They don't want to move. It hurts. Why would I move? If you've ever had any surgery yourself, you know, the first thing they do, no matter what you've had done, they get you up and moving just as quick as possible. So, you know, that's because they don't want us to become immobile when we're in recovery, and the same should be done with our patients. Sometimes a patient will have an altered sleep pattern. They may be sleeping all the time, or they can't sleep and they're getting restless and they're constantly moving around. And they can change their behavior. The most timid animal in the world can suddenly become very aggressive, and vice versa. So when we look at pain recognition, there are also physical signs or physiological signs that happen. And as I said, you know, when you're doing a spay or neuter and they're getting ready to tug on some ligaments in the abdomen, the patient's going to increase, their blood pressure is going to go up, their heart rate goes up, their respiration goes up. So these are signs that there's pain there. And in addition to that, we also have kind of blanched mucous membranes. So when we're in pain, all of these things happen. So these can be physiological signs of pain. Now there's also the physical signs, and dogs and cats differ in how they present us with pain. Now, not too many dogs, you literally bark, ouch, that hurts, but they might whine or they might whimper a little bit. Again, as I said, they could become either timid or very aggressive, and that wasn't their normal behavior. A dog who's painful will usually just kind of sit and stare, kind of a fixed stare off into space, and they're restless. They can't get comfortable. They're constantly walking in their cage and turning around, can't lay down. They lay down for a few seconds, they're up moving around. Cats will purr when they're painful. They'll also growl, and they'll also excessively groom. But a cat who is painful will purr. So one of my toughest discussions I've ever had in a clinic was a cat who came in with level 3 to 4 tooth resorptions in its mouth, which are very, very painful. And the pet owners refused to believe me that he was painful because he was purring the whole time. So I explained that I've had cats with fractured pelvises purr because it's a way of calming themselves down. Now, we all know that cats like to hide. Cats who are painful will hide. So an animal who comes home from a painful procedure at the veterinary hospital, you know, you call to check on him and the owner's going, well, I think he's okay. I really haven't seen him for 2 to 3 days because he's hiding under the bed or somewhere. So we need to make sure we tell the owners that hiding is not good, okay? And a cat will also just squint when they're painful, and they don't want to move around, okay? They're not going to be too restless. They're just going to kind of huddle up and squint off into space. Now, there's really some really good things out there now, and that's things called pain assessment tools. And when we use pain assessment tools, I don't have one in this presentation, but you really need to know what's normal. And if you can, you should watch that patient from a distance before you have any interaction with them, because they're going to act a little different once you're having interaction with them. Of course, you also want to then have that interactive evaluation to see, you know, if you move this joint, is that painful? We need to record our findings. I really am a big believer in making sure that your entire team and staff is trained so that when you're using some type of pain assessment tool, everybody's giving pretty much the same score. So there's some really great tools available. If you go to Colorado State University, they have some pain scales that you can download. They have one for dogs, they have one for cats. And then you can also do some, you know, Googling on what's called a grimace scale. And they have them for so many species now. In fact, I saw one recently for donkeys, but they have them out for dogs and cats and things. And what it's going to do is kind of what their facial features look like. And it's like if you've gone to the emergency room with a child or to the doctor may say, okay, which one of these faces are you right now? And they've got like 10 different faces for the child to kind of pick where they feel at. So you can look at those things and have your team trained to assess pain. Now, when I talk about balanced pain management, the reason we want to do this is, remember, we talked about those pain pathways. We want to block the pain in all those different pathways, but we also want to prevent inflammation. And inflammation is painful. It's red swelling pain, okay? And inflammation in itself sometimes is good because it's there to kind of help heal, but it also can become pathologic if it's not treated. And another thing we want to prevent is windup. And what windup is it's when you let pain get so bad that it's going to take twice as much medication to treat it. So for instance, relating to a human, I get migraines. if I think, okay, I'm getting a migraine, I can feel it coming on. It's going to get better in a couple, I'll wait a half hour, it'll get better. And it just keeps getting worse and worse and worse. Well, by the time I finally give in and take medication to help with the migraine, I have to take almost twice as much to have any effect. So we want to prevent windup by getting that medication on board early so that we don't have to have windup happening. And remember, if we have windup, it reduces the efficacy of our drugs. So we really want to make sure we're being proactive on that. We want to suppress any of the neuroendocrine stress response to pain and injury. And of course, when we have an animal who is less painful, it's going to shorten their convalescence and their tissue is going to heal faster. So again, as I said, let's say we have a patient going into surgery, we want to give them a preemptive analgesia of some sort. We want to avoid that windup. Plus we want to also kind of help that patient feel better throughout the anesthetic procedure. So we can go ahead and use something like an opioids, alpha-2 antagonist, and an NSAID. All of those things, and even in combination, are going to really help that patient feel better. We can also use local blocks, nerve blocks. We can do all kinds of different blocks, testicular blocks when we're looking at neuters, things like that can really help that patient feel better. We know we can't eliminate the pain they're going to feel postoperatively, but we can minimize it. All right. So we can kind of keep them a lot less painful than we would if we weren't giving them anything. So we're going to talk really briefly about nerve blocks, the ones that I recommend doing. And I will tell you, if you had 10 people teaching you to do veterinary dental nerve blocks, you're going to have 10 different ways of doing it. Okay, we all kind of have our own ways to do it. It's working when your doctor starts to do an extraction and you don't have to do the old crank the anesthetic up. The first time I did nerve blocks on patients, it was for canine extractions on fairly healthy teeth that had been fractured. And I did my first block. I maintained that patient at under 1% isoflurane for the entire extraction. So that's when I became a hallelujah. I know nerve blocks work. Let's use them all the time. All right. You don't want to inject into really infected tissue. So if there's a way to kind of get around that, you want to make that happen. We do realize that the drugs we use with nerve blocks can cause toxicity if they're got directly into the bloodstream. They can cause, heart palpitations, AFib, things like that. They can also cause self-mutilation. So if you've ever had a dental block done, I talk like this when I've had a block done so that I don't accidentally bite my tongue or my cheek because I don't want to have that feeling because I can't feel me do it. And then all of a sudden my tongue hurts when it comes back to normal sensation. But a dog doesn't know better and they're going to chew. And I've heard stories, I guess, of patients that have really done some pretty bad damage. One thing you can do when you do this is to recover them in their normal sternal recumbency, where their tongue is more in its normal location instead of hanging out the side of their mouth. Sometimes some patients wake up kind of pawing and feeling their face because they can't feel it and they're a little anxious. You might need to give them just a little bit of something, maybe Dexdomitor or something, just to take the edge off to help with that anxiety. Now, I'm going through a very quick overview of the blocks that we use. This is not by any way meant to be an opportunity for you to go perform these blocks. Okay, you really need to go get additional continuing education and hopefully in a lab setting before you actually perform these blocks on a patient. When you do perform blocks, you don't need to go out and buy really fancy stuff, okay? A tuberculin syringe, maybe a 3mm syringe for a really large dog is all you need. Usually I use 25 gauge needles and I have a lot of them there. I use a little tray from the top of my vaccines. I use that kind of as my tray. I'm going to put a lot of needles in there and I usually put two syringes. It's kind of, it's a little bit of a jinx for me. If I only have one syringe, I'm going to need the second one. And then I have my drug available and my drug of choice is bupivacaine, 0.5%. Now there's other drugs available. I'm not a big fan of just using lidocaine. Lidocaine alone does not last very long. It sets on very quick, but it only lasts about an hour to an hour and a half. I want something that's going to last anywhere between 6 to 8 hours. And bupivacaine, according to most textbooks, is anywhere between 6 to 12 hours, depending on which textbook you read. So there are other things out there that are much better. None of these are very expensive. Lidocaine and bupivacaine used to be mixed all the time because we thought we'd do the lidocaine for early onset, bupivacaine because it lasts longer, but we found out when we mix them, they actually decrease their efficacy. So it probably has been 15 years since I've mixed the two together. So just be aware of that. And if you can't give bupivacaine, which I know sometimes it's on back order, there are other options, mepivacaine, ropivacaine, or other things that we can use. Now, I never give too much in a site. I have a whole dose for that animal, and it might be 8 to 10 millimeters on a really, or 8 to 10 mils on a really big dog if I, drew up the whole dose. But I'm never going to use that much. In a small dog or cat, I never go between 0.01 to 0.015 mils per site. For large dogs, I might go up to 0.3 to 0.5 mils per site. So it doesn't take a lot to really get effect with this. Now, if I want something that's going to last longer in a block, longer than the buprenorphine, excuse me, my brain just went dead. The Marcaine. If I want something to last longer than that, I can add just a little tiny bit of buprenorphine to this drug. And basically it's going to make it last. Some people report up to 24 hours if we add the buprenorphine to it. And it's really a tiny, tiny amount. It's 0.003 megs per kg, basically a hub. Okay, but just a dash of this will make a bit. Always do the math and calculate it out. You can also use dexamethasone to this, 1 to 2 micrograms per kg. There's really no studies that show that this is effective in dogs that have been published. There's a lot of anecdotal information out there that it works for dogs. We know it does help in humans as well as rats. So use that, kind of knowing that there's really no studies on that. One of the blocks you can do is a field block. So if you've got that really bad tissue and it's really nasty and you can't go where you really should be doing the regional block, you can go ahead and block an individual tooth. And all you're going to use is, you're going to just infiltrate the gingival tissue around that tooth. So you're just going to kind of insert the needle and infiltrate the tissue. I use this a lot with deciduous teeth. Yes, I block deciduous teeth removals. So I know that dental pain hurts. I don't want my patient to be painful. The first block I'm going to use is an infraorbital block. Now, I don't use this very often. I'm going to show you 4 blocks. I don't use the infraorbital block all that often because the way I do it, I'm only going to block my canines and incisors. And most of the time I need to block some of the cheek teeth or farther back teeth. So I never go into a foramen. All right. I know a lot of people teach going into the foramen because you can get all the way back. But you know what? There's nerves in there. There's blood vessels in there. And oh, yeah, sometimes there's an eyeball right there. So I just go up to the edge of the foramen. And the foramen is located right over the maxillary third premolar. And you can almost always palpate it on an animal. I usually will hold my needle along the mucosa of the maxilla, and I'm going right to the edge of that. I'm going to inject, or excuse me, make sure I'm not in a blood vessel. So I'm always going to aspirate a little bit, rotate the needle once or twice, aspirate, and then I'm going to inject and create a bleb. When I create the bleb, I remove my needle, I lift the nose up, put digital pressure, and force that drug into the foramen. But remember, it's only going to block my canines and incisors. This is why I don't do it on cats and small brachycephalic animals, because there's an eyeball right there. I rarely, if ever, do this block on a small dog, brachycephalic or cat. Nobody wants to do this by accident. Another block we use a lot, I like this one, this is kind of my go-to maxillary block, is the caudal maxillary block. And when I do this, I'm going to block, there's a nerve bundle that runs all the way through here, okay? And it's the same one I would hit if I came in through the infraorbital, but I'm going to hit that nerve bundle back here at the rear, and I'm just, and I'm just going to bathe that nerve bundle in the anesthetic. So I come at mine kind of at a diagonal. There's a little It's a real technical term, but kind of a soft squishy area right up here, right underneath the zygomatic arch. I come in, cross my needle over my first molar, come in, point inwards a little bit, aspirate once or twice, make sure I'm not in a blood vessel, and inject. Digital pressure again, but this will block the entire maxilla. If I'm looking at the mandible, I can go ahead and do a middle mental block. Again, though, this only blocks my canines and incisors, so it's not something I'm going to do very often. There's two ways to approach this, and by the way, you can very rarely, if ever, palpate this foramen because there's the frenulum there. There's a lot of tissue right there that kind of attaches the bottom lip, but it is right below the mesial root of the second premolar. And you can come at it either straight or you can do the angle I usually do, kind of using my canine tooth as a prop. And you just go to the edge, aspirate, rotate, create your bleb, digital pressure and a little gravity, lift that nose up and let gravity do its work. Now, I love the mandibular nerve block, or also known as the inferior alveolar foramen block. There's two ways to do this. One is intraoral, the other is extraoral. The intraoral, I'm going to show you a picture of it. I've never actually done this block, to be quite honest with you, because when I learned to do nerve blocks, I was taught that this block is going to be more likely to cause tongue numbness. And I don't want to have a numb tongue, okay? I don't want my animal to chew the tongue off. So I'm going to go ahead and do the extraoral approach because it's a little safer and it's really kind of cool to do. But it's a transcutaneous approach. And this is going to block all the teeth in the animal's mandible on the side it's administered. Now, this is what I'm trying to hit, okay? There's no way I'm going to get my needle into it because, yeah, I can't do that without taking the jaw off. That's not a fun thing to do. So we're going to kind of come up to it from the bottom and just to the edge of that foramen. This is doing the internal one. We pull the tongue off to the side. We kind of scrape that needle along the bone right to the edge of that foramen. Like I said, I don't do this block. I actually do an external one, and I will have my finger in the mouth and I will feel for this notch. And many of our dogs will have a notch. We have one here kind of on the back of the ramus. If they don't have a notch, just drop a plumb line from the lateral canthus of their eye straight down. Okay, if we go straight down, that's where we want to inject. I put my finger in there so I can kind of see my finger moving below the mandible. I pull my finger away when I'm actually inserting the needle. Knock on wood, I've never stuck myself. But I come in at almost a 90-degree angle, and then I turn the needle and I scrape along the bone. And the reason I do that is I want to make sure I'm along the bone and I'm not on the outside of the membranes and the tissues along that mouth. So I'm going to go ahead and just kind of come in that way. My finger is in there because I can feel the needle when it's in the proper spot. Now you can never really, once in a blue moon, you can actually palpate that foramen. But for the most part, I want to make sure my needle is on the medial aspect of the mandible and not on the outside of it. And this is really what I'm trying to do. I'm just coming up, getting right beside that foramen and inject. What's really important to remember on all of the nerve blocks is you don't want to hit the nerve because that causes some nerve damage and takes a lot of time to heal. We just want to bathe that nerve in the medication. So we're not actually trying to lacerate the nerve. We're just trying to bathe it in the medication we're giving. Now, as I said, all of these blocks, you need to practice. You need to practice on cadavers. You need to look at skulls so you know where these nerves should be running. And this is not intended to be, go out and place a block tomorrow or this afternoon. Okay, so just be aware of that. When we're looking at postoperative pain, we really want to look at, we want to make sure we send our patients home, or if they're in the shelter, that they're getting pain management after the procedure. Because remember, it affects healing. We should be putting them on an opioid of some sort before they leave the hospital. We should be giving them good NSAIDs. Even neuropathic pain meds have been really shown to do great jobs with dental pain. So things like gabapentin have been working really well in some of our patients. We do need to make sure if you're sending a patient home on gabapentin that the pet owner realizes they're going to be kind of out of it for a while. Gabapentin can make it pretty mellow. So let's talk about a case report real quick. This is an 11-year-old neutered male, domestic long hair. He presented for what we call full mouth extractions. And this is because he had gingiva stomatitis. He had been fighting gingiva stomatitis for 2 years. They'd had him on steroids, cyclosporin, opioids, pain medication, chlorambucil. They've had him on everything. But he kept having breakouts of the gingiva stomatitis, which is referred to as refractory gingiva stomatitis. And he just continued even after these full mouth extractions to have problems. The rechecks were showing that he continued to have inflammation and proliferation in the back caudal aspect of his mouth. It is important to realize that this case was actually done with a diplomate in dentistry. So we knew that they had done follow-up x-rays to make sure they had gotten all the fragments of the roots out, and there was no problems with that. The treatment continued. They continued him on convenia and then even mirtazapine as, trying to get him some pain, some relief. They also put him on Depomedrol, which they decided to quit fairly quickly because he developed diabetes from that. Keeping a patient on Depo is not a good idea, even though we all feel better after a steroid, but it's not good for their bodies. They had him on other drugs too, trying to keep that pain that stomatitis at bay, as even just having buprenorphine that was, just injected in the animal's mouth for pain. But then they added the Assisi loop. And they put him in this loop, what they call the Assisi lounge, which had loops in the bottom, and we'll show a picture of it. But they put him in there 4 times a day for 15 minutes. And we really started to see some improvement. Now, they had done, I'm just going to show you, they did some pre-anesthetic blood work. He had all the good pain management beforehand, was induced with propofol and maintained on ISO. But really within 2 weeks, this patient, his swelling was still there. His erythemia was improving. It wasn't gone, but it was improving. He loved actually being in his loop lounge because he got to play with a catnip toy when he was in there. Who doesn't like a catnip toy? Within about 4 weeks, the erythemia was almost gone, but the proliferation of that tissue remained unchanged. Even at 6 weeks, the erythemia was almost down to 3 millimeters, but the cat was eating again. He was gaining weight. He was starting to feel better. This cat had lost a tremendous amount of weight because he didn't want to eat. Nobody wants to eat when your mouth is hurting, right? Over time and over several months, he actually continued to gain weight, and they were able to discontinue his meds altogether. And this is just an example of what the Assisi loop looks like for this lounge. Now you can put cats in here, you can put small dogs in here. And they also have loops, obviously, for bigger dogs that isn't going to be a lounge situation like this. So basically, I'm running out of time here, but I just wanted to make sure you realize that pain management is mandatory, okay? We should not let animals suffer in pain. Multimodal approach is really the best way to go, and the pain management risks outweigh the benefit of the analgesic drugs administration.